Hello and welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds. My name is Joe Ceramelli and I oversee Grand Rounds for our department. Thanks for joining today. I wanted to mention a few things before talking about today's presenters. During the presentation, you can write in questions or comments in the Q&A or in the chat, and I'll collect those and can go through those with the presenters at the end. There's a group of us that works on Grand Rounds, including Samhar Abraha and Mike Walker. We do record and archive the Grand Rounds presentations on the Department of Psychiatry and Behavioral Sciences website. Today's presentation specifically, and the series is partly funded by the Garvey Institute for Brain Health Solutions and the Ripley Fund. Towards the end of the presentation, I'll put in a link in the chat for a 4 or 5 question Grand Rounds evaluation. The responses there are helpful for me with communicating with presenters and with planning Grand Rounds. So a little bit about today's presentation. This is what I'll call part 2 of what we had as a 2-part presentation series on neuropsychiatric aspects of COVID-19. With the first part being more clinical aspects, and now with understanding symptoms and a research focus. And we have 2 presenters today from within UW Medicine, Dr. Rebecca Hendrickson from the Department of Psychiatry and Behavioral Sciences, and Dr. John Oakley from the Department of Neurology. And they are collaborating together on what's called the Seattle Recover Study, which is an ongoing study funded by the Garvey Institute for Brain Health Solutions, which they'll tell you about in detail today. A quick summary about each person, then we'll get right to their presentation. First with Dr. Hendrickson, who is an assistant professor in the Department of Psychiatry and Behavioral Sciences and a research investigator at the VA Northwest MyRec. Dr. Hendrickson has developed research and clinical programs related to PTSD and how noradrenergic signaling affects symptoms. Dr. Oakley, Dr. John Oakley is a neurologist and neuroscientist, and is an associate professor in the Department of Neurology and adjunct in pharmacology. Dr. Oakley focuses on mechanisms of epilepsy and mechanisms leading to impaired autonomic nervous system signaling. It's interesting, both maybe my summary of it, but they can tell you the truth. Both seem to focus on the mechanisms and development of symptomatic conditions within the nervous system. And would be very interesting to hear about this as it relates to COVID-19. And I could stop there and turn it over to Dr. Oakley and Dr. Hendrickson.
All right, am I successfully slide sharing?
Yes.
Great. Let me know if anything comes up with the sound, but otherwise I'll go ahead and start. We are excited to talk to folks today. And I actually want to start out with an example of the kind of clinical context where John and I are hoping the information we present will be pretty immediately relevant to a lot of people. So Tanya is a hypothetical patient, so fictional, but representative of folks that we've seen in clinic, who comes in with a chief complaint of insomnia and fatigue that are pretty severe for the past 2 to 3 months. Her family thinks she's maybe depressed. She thinks mostly it's true she's not really enjoying things, but that's largely because she actually just feels awful. On review of systems, she endorses chronic headaches, diffuse body pain, significant frequent episodes of anxiety, chronic nausea, heart palpitations that are particularly prominent when she stands up, either initially or for ongoing periods of time, and low exercise tolerance. And all of these things are primarily during the same 2 to 3 month period. She does report she had an infection with COVID-19 about 4 months ago, but she's not really sure whether this seems like it's related. It was mild, it resolved, and if it's connected to the current symptoms, they didn't start right away. She seemed to be fine afterwards, and then the current symptoms started sort of gradually over the following month or 2. And in the office now, her labs are normal and her seated vital signs are unremarkable. So, in other words, Tanya's presenting with complex chronic somatic symptoms without an obvious specific cause. When we talk more about past history, she reports no formal psychiatric history, but did have periods of increased anxiety as a teenager. As an adult, she's had some sort of 3 to 6 month periods where she noticed some heart palpitations that were a little distracting, some chronic nausea and headaches. And she's actually identified a couple of things that may have precipitated these prior episodes. One followed a couple of mild concussions during sporting that came kind of close together in time. And another overlapped significantly with a really grueling, stressful work environment. But she wants to emphasize it has never been this bad before. So yes, she's had some symptoms like this in the past, but at this point she's missing work shifts, it's affecting her parenting, and it's getting worse, not better. She really needs something to do about this. Now, I think if we're honest, this type of symptom presentation is a kind that a lot of us in medicine don't always feel like we have the most effective tools for dealing with. People come with really legitimate questions like, is this just stress? Do I need a medical workup? If so, who should I be going to see? And what is it that I can do that will actually help address these symptoms? And while a lot of us feel like we have a list of treatments we could consider and we hope might work, we don't necessarily have a clear understanding of what's causing these symptoms to help us choose one that we're particularly confident is likely to be helpful. So part of our goal today is to leave you with a more solid foundation for thinking about these kinds of complex chronic somatic symptoms and how they relate or don't to our core domain of psychiatry. So we're going to start out first with how we got here, how medicine has understood these clusters of symptoms over time, and some of the limitations of our current frameworks and assumptions when we think about these symptom clusters. And then we'll talk about the way that we've been moving towards conceptualizing these kinds of complex symptoms in both our research and clinical practice. We'll give you an example of how we're currently applying and exploring this conceptual model in our ongoing post-COVID research project, and we'll share some of our early results. And then finally, we'll into some clinical strategies that draw on this model that we hope you can use pretty here and now. So the observation that people can have complex and potentially severe and disabling somatic symptoms without any obvious underlying pathologic lesion has been one we've been grappling with for quite some time. During and following the US Civil War, physician Jacob da Costa described a pattern seen widely in those who had fought and in those who were exposed to the war that he termed irritable heart, to highlight its core component of a rapid heart rate that jumped up with only mild exertions, or sometimes for no obvious reason at all. But he also highlighted the range of associated symptoms, such as fatigue, shortness of breath, without any obvious pulmonary problems, and even insomnia that seemed to go with it. Finally, he and his contemporaries were clear that it was not only combat that seemed to precipitate this condition. Diarrheal illnesses and general overexertion were also key risk factors. Following World War I, James McKenzie in Britain picked up on this work and added in the prominence of vasomotor symptoms and the general absence of feeling well. And again, emphasized the connection both to exposure to war, but also to acute viral illnesses and severe strain in general. Now, the names we've used in medicine to talk about these types of clusters of symptoms have continued to shift over time. So for example, I learned a surprising amount about mitral valve prolapse syndrome in medical school, only to hear almost nothing about it once I entered practice. While the current most common diagnosis used for particularly these types of cardiac symptoms is probably POTS, postural orthostatic tachycardia syndrome. It continues to be clear, though, that for a significant variety of these symptoms, there's a wide variety of physiologic stressors that seem to be able to precipitate them. And particularly relevant right now, COVID-19 is looking like it may be a particularly potent viral precipitant.
So what I'm showing here is a large list of symptoms that are common to patients that I see and other people see in autonomic clinics. These symptoms are the kinds of symptoms that Rebecca just mentioned that people have known about and described for more than 100 years. In modern medicine, we've kind of taken the approach of compartmentalizing these symptoms. Part of that might be because the medical system is designed to address symptoms by organ system and by subspecialty. And this can sometimes give you the impression that these symptoms are completely separable from one another. They may be completely independent processes. But one of the things that really struck me a number of years ago when I started working with patients with these symptoms in clinic is that they often, or maybe almost always, tend to co-occur in this patient population. And this leads to some challenges. As a resident, maybe we kind of joke about people who have pan review of systems, kind of have symptoms in all these different organ systems, and it's just very difficult to understand how to organize that and understand it. Maybe it feels like someone can't possibly have all these symptoms. It doesn't make any sense. We don't have a good model for trying to understand where they come from. And one of the approaches to this has been to organize these symptoms into syndromic diagnoses, which I've identified here. So on the right, we have digestive symptoms like nausea, bloating, diarrhea, constipation, abdominal pain that fall under a category of irritable bowel syndrome. Symptoms that are more central, like fatigue and weakness, and cognitive symptoms like brain fog, insomnia, anxiety, depression, problems with attention are common to chronic fatigue syndrome. Pain in muscles or joints is in the fibromyalgia spectrum. We also have people who have chronic headaches. The somewhat newer syndrome in this group is postural tachycardia syndrome, in which people have fast heart rate and palpitations and increased risk of fainting, as well as dizziness and tremors. Another common symptom category is urinary, with a sense of urgency and frequency, sometimes sort of falling into the category of overactive bladder. So you can see how we've sort of taken this set of symptoms and kind of classified it into these different syndromic diagnoses. One of the common features of the syndromic diagnoses is that often there really isn't good objective test finding to prove that somebody has this diagnosis. And in fact, one of the components of diagnosis often is doing testing that we have available to kind of rule out other potential causes. But in a sense, the co-occurrence of these symptoms actually does seem to be specific for something. And the fact that they tend to co-occur frequently in the same patients really, I think, points to the possibility of a single underlying common pathophysiologic mechanism. Okay, next slide. So on the autonomic nervous system side, there has been some development in testing that I think has given us a little bit of insight into where these symptoms might come from. We have standardized autonomic testing that involves some simple blood pressure measurements during tilt table testing and some other provoking maneuvers that allow us to look at how the autonomic nervous system is regulating heart rate and blood pressure. Now, people with chronic fatigue syndrome and fibromyalgia and postural tachycardia syndrome all have orthostatic intolerance. They have symptoms that are there when they're standing and improve when they lie flat. Autonomic testing now has given us a little bit of an insight into exactly what people are experiencing physiologically with those symptoms. So I put a quick example of what a tilt table trace would look like in somebody with postural tachycardia syndrome. At the top, there's a trace of the interval between heartbeats, they're called RR interval, kind of an upside down heart rate. And below, we have beat to beat continuous blood pressure measuring. So you can see the bottom red line is diastolic blood pressure, the top red line is systolic blood pressure, essentially one measurement every time the heart beats. There's a green triangle at the bottom that indicates where the tilt table goes up. And you can see there's a very rapid increase in heart rate that happens almost as fast as the tilt table goes up. And then at the end of a 20-minute tilt, 15-minute tilt, I guess in this case, the heart rate rapidly declines back to baseline. So for this patient, they had a resting heart rate of 60. It goes up to 115 beats per minute. That's really an excessive increase in heart rate. That's a heart rate increase that you wouldn't expect to need simply upon being upright. So it gives us some insight that the autonomic system is not regulating blood pressure and heart rate in a normal way. And other work on patients with POTS and chronic fatigue syndrome has demonstrated that there's an elevated level of baseline norepinephrine, and for many patients, a greater than expected increase in circulating norepinephrine going from supine to upright. And this kind of makes sense with what we see physiologically. Fast heart rate is really, apart from people who have arrhythmias, fast heart rate is really driven by increase in noradrenergic signaling. And so it fits with the physiology that we see. Other findings have demonstrated that some patients have increased basal vascular tone, and that tone actually increases further when they go from seated to standing position. A component of that increased vascular tone seems to be due to excessive sympathetic nerve activity, norepinephrine release, and activation of these alpha-1 receptors on blood vessels that lead to vasoconstriction. Next slide. So there have been other explanatory models proposed for these symptoms. People have considered viral causes like latent viral infections, and I think COVID would potentially fall into that category. Lyme disease has also been proposed, as well as EBV. Chronic immune dysfunction, autoimmune disease with chronic low-grade central inflammation has been proposed. Musculoskeletal problems like cervical myelopathy, cranial cervical instability. There's a group of patients who have joint hypermobility, and there's been some thought about relationship with connective tissue disorders. On the neurologic side, there's been a lot of focus on small fiber neuropathy and impaired signaling in the autonomic system, potentially through autoimmune mechanisms that would injure small nerve fibers. On the psychiatric side, there's been this observation that people are more likely to have comorbid mood disorders, and that potentially some of the described somatic symptoms are actually reflective of kind of a disrupted perception of or experience of physical symptoms. But none of these explanatory models does a very good job of explaining all the full constellation of, excuse me, full constellation of symptoms that people experience. And unfortunately, none of these models has really led to effective treatment strategies for these symptoms, and the patients remain highly symptomatic. Next. In addition to that, I think there's some difficulty in trying to decide what the best treatment approach is for these patients. So on the mental health side, there seems to be kind of an implicit assumption that effective treatment and management of mental health components will by necessity resolve or substantially improve somatic symptoms, whereas on the somatic side, there's sort of an assumption that optimal treatment of the physical aspects of the problem will improve cognitive symptoms like attention and fatigue. But none of these have actually been proven to be true. Next. So we know that many of the physical symptoms that people experience are those that you would expect from elevated noradrenergic signaling, including things like palpitations, tachycardia, tremors, sweating, a component of people's nausea. We also have recognized through work in PTSD and other disorders by people at our institute and other groups that dysregulation of central noradrenergic signaling in conditions like PTSD can result in some of the CNS and cognitive symptoms that we see as comorbidities, things like fatigue, executive dysfunction, changes in processing speed, sleep fragmentation as examples. And this has led us to kind of consider a model in which there is a change in the regulation of both peripheral noradrenergic signaling and central noradrenergic signaling, and that the change in regulation results in kind of a parallel disruption of both peripheral and central noradrenergic signaling in a way that can explain this common co-occurrence of central nervous system symptoms and peripheral symptoms that we see in clinic, and in particular that we see now in patients with long COVID. So next component. So an example of this is the baroreflex. Baroreflex is a very straightforward reflex at face value in which blood pressure is sensed in the body. Signals are sent to the brainstem, processed and compared to a set point, and then rapid adjustments are made in parasympathetic and sympathetic signaling to make small changes in heart rate in an attempt to kind of buffer blood pressure in response to blood pressure changes from standing or respiration or other things. That simple reflex pattern is actually highly modified by central systems, such that the sensitivity of the system, the set point, the speed at which the system responds are all varied in a number of different ways by these central inputs. So this is an example of how a change in central regulation may occur in parallel with peripheral regulation. Okay, next.
So an important feature of this model then is that it makes a number of specific testable predictions. First, that peripheral, so somatic, and central, so CNS symptoms should co-vary both across time and within an individual and across a population. Second, it predicts that if these different types of physiologic stressors, such as a traumatic brain injury, a traumatic stress, or a physiologic response to infection, if they're all at some point acting on a common physiologic set of pathways, they should have the potential to interact with each other. So for example, someone with a history of traumatic stress who then develops an infection with COVID might have a higher chance of experiencing persistent symptoms following that infection than someone without the prior history of traumatic stress. And third, we think this model predicts that symptoms should track physiology. For example, if in our work, we're testing in particular the hypothesis that increased adrenergic signaling is going to be leading to significant components of symptom expression, we should be able to see a direct relationship between our biologic measures of adrenergic signaling and the kind of symptoms we're talking about. So to test these predictions, John and I have been working with a really fantastic team of collaborators across the UW and VA to put together what I've been lately calling the Seattle Recover Study to distinguish it from the unfortunately simultaneously and identically named but absolutely unrelated NIH Recover Study. In this study, we invited any US adults aged 21 to 65 who are willing to complete a baseline assessment of exposure history, somatic and mental health symptoms, and cognitive functioning. And then we invited those who on this baseline survey reported chronic somatic symptoms to continue following up monthly with surveys for an additional year. And this portion of the study is actually implemented entirely online using Qualtrics and the online neurocognitive testing environment Test My Brain from the Mini Brains project at Harvard. And finally, for a much smaller subset of folks who are reporting significant increased somatic symptoms following a documented COVID infection, and they also happen to be local to Seattle, we're now inviting those folks who express interest to participate in a set of in-person assessments, which include clinical interview, neuropsychological testing, a sleep study, pupillometry, and autonomic testing focused on cardiovascular reactivity. So today we're going to share some of the preliminary results from just this initial baseline assessment from the first 326 participants. So of these participants, about 2/3 reported at least one period of known or probable COVID infection. And we have a lot of details about how to try and assess that, but we're just lumping it all together here. While a third reported no known history of COVID-19 infection, at least at the time of this baseline survey. It would be harder to get these numbers now. When asked whether they considered themselves someone with long haul COVID or persistent symptoms after COVID-19, about equal numbers said yes or no, with a smaller group in the middle that was unsure. To take a first look at what kind of data we were getting, we looked at what kinds of symptoms folks who reported having long COVID were experiencing compared to the rest of the group. So using a self-report measure of peripheral autonomic symptom burden called the COMPAS 31, we found that those who reported experiencing long COVID were reporting significantly higher autonomic symptom burden. And they also reported significantly worsened cognitive functioning using the NeuroQoL. We looked at these same measures as well as a function of just known history of COVID-19 infection versus no known history of infection. And we found that history of COVID infection was itself associated with increased autonomic symptoms and decreased cognitive functioning and self-report. So based on this kind of data, we concluded that we seem to have the right population and we seem to be measuring relevant symptom domains. So what can we conclude about our core predictions then? So the first thing we asked was whether peripheral and central symptoms co-varied, starting with a very straightforward look at the correlation between self-reported autonomic symptom burden and self-reported cognitive functioning. And we found, wow, they really absolutely relate. So folks who program in R may recognize this p-value as one that comes up when you have maxed out the default print function for how small a p-value can be in your statistics in their software. So that is a very strong relationship. We also tested this in a slightly more statistically sophisticated way by testing whether peripheral autonomic symptom burden serves as a statistical mediator of 4 different system clusters commonly reported in long COVID, covering physical health, mental health, cognitive functioning, and fatigue. And I want to be clear that when I'm saying statistical mediator, I'm not asking whether peripheral autonomic symptoms are a literal causal mediator of the other types of symptoms. Instead, we're just using this as a statistical tool to ask how much knowing a particular person's peripheral autonomic symptom burden plus some other standard covariates is able to tell us about their likely degree of symptom burden in these other areas. In other words, it's just a different way to ask the same question of whether these symptoms covary the way our model predicts they will. And the results show you a couple of different things. So on the left, you can see the total effects of COVID-19 history on symptom burden in each domain. And these are represented in, for our purposes here, pretty much arbitrary units. And you can see that for all 4 symptom clusters, reporting you have at least 1 episode of known COVID infection is indeed associated with a significantly higher total symptom burden in each domain. On the right, you can see the proportion of that total effect that's mediated statistically by peripheral autonomic symptom burden for each of these 4 types of symptoms. And you can see it's a substantial proportion of the effect across all of these domains, consistent with our model's prediction. I do want to acknowledge, though, that it's not 100% of the effect. In fact, there appears to be some specificity to this, where fatigue and maybe cognition have a larger proportion of the effect that's independent of the peripheral autonomic symptoms. And I think this is actually somewhat reassuring. It's what we would expect to see if the underlying biology driving central and peripheral symptoms is co-regulated, but it's not always perfectly aligned. So next we asked whether we see evidence that our different potential causes of altered stress threat regulation show evidence of interacting with each other, the way we expect if they are feeding into a set of common physiologic pathways. So again, we looked at this first, an analysis that stays pretty close to the raw data. We looked at autonomic symptom burden as a function of both COVID history and probable lifetime trauma burden. And we inferred this from the life events checklist, which is imperfect, but accessible measure of probable lifetime trauma exposure. And we found that, as we expected, both COVID history and trauma history are independently and significantly associated with autonomic symptom burden in this population. When we looked a little more closely at these results, using a multivariable regression model, we found that not only are COVID history and trauma history both significant independent predictors of autonomic symptom burden, there's also a significant positive interaction between them. In other words, the effect is synergistic, with the combination of experiencing increases in the risk of symptoms happening more if you have both COVID history and a history of trauma than with either experience alone, which is consistent with our model and frankly consistent highly with our clinical experience. So our third prediction, testing the relationship of symptom expression to specific biologic mechanisms, is one that we are working on data collection for now. So instead of results, I'm just going to plead for help with recruitment. So if you know of anyone living in the US age 21 to 65 who might be interested in completing our surveys, we would love for you to pass along the link to the survey. So tinyurl.com/recoverstudy. It's also on my faculty webpage. And the URL will just take you to the Qualtrics page that starts with information about the study and eligibility assessment. And it's actually a self-enrollment study. For folks who participate in the online portion, also have a documented history of COVID-19 infection that was followed by a persistent increase in complex somatic symptoms. There'll be a chance to indicate if you're interested in participating in in-person assessments, which we are actively recruiting for right now. But since I can't give you those results yet, I'm going to add one more interesting finding from our online neurocognitive testing data. So drawing in the expertise of our neuropsychologist, Dr. Katie Pagelayan, we are interested in asking whether this self-reported cognitive dysfunction shows up on objective cognitive testing, using, again, this self-administered but objective online cognitive testing platform from Test My Brain. We used 6 different cognitive tests, and I'm only showing you 3 for simplicity. And we found that some of them, for example, this test of concentration on the left, had no real relationship to participants' self-report of overall cognitive functioning. But for other tests, particularly those like these 2 on the right, that are especially sensitive to changes in processing speed, we found a really interesting result. So for participants without a known history of COVID-19 infection, the ones shown in sort of this pink color, there was no meaningful relationship between performance on these particular tests and subjective cognitive functioning. But for folks with a known history of COVID-19 infection, so that's the blue teal, there was a strong relationship between their self-reported cognitive functioning and their objective performance on those tests. So to answer our initial question, yes, for those with a history of COVID infection, self-reported problems with cognition do appear to be significantly related to differences in objective performance. And preliminarily, these differences may be particularly in the area of processing speed. So to conclude the initial research portion of the talk, I've told you about 3 initial findings. That peripheral and central symptoms are both significant in this population and they co-vary. That COVID-19 infection and a history of traumatic stress both increase the risk of symptoms commonly associated with COVID-19, and they do so in what appears to be an actually synergistic manner. And finally, that subjective functioning deficits are associated with difference in objective cognitive testing. And together, these findings are consistent with our initial hypotheses that complex chronic somatic symptoms that are often reported following COVID-19 infection may reflect a common underlying mechanism that is co-regulated across the central and peripheral systems. Looking forwards, we are very excited to be working to complete our in-person assessments to test the role of altered regulation of adrenergic signaling in symptom expression. We think it'll be important to explore the impact of different types of stress and also the sort of temporal patterning of stress, both across an individual's history of development and across a period of time on the risk of developing these symptoms. And then finally, above all else, John and I are clinicians, and as soon as we, believe that our results are able to point to a potential intervention that is likely to effectively modulate these core mechanisms and result in real meaningful symptom reduction, and as soon as we have ways of identifying the patient population most likely to benefit from these interventions, we would really love to move directly to clinical treatment trials. So I've gone slightly fast. I apologize because I'm actually really excited to leave time for the last portion, where John's going to talk about some of the clinical strategies you can use now to talk about and treat some of these symptom patterns in patients.
All right, thank you. So what I'm going to discuss is my clinical approach in autonomic clinic to working with these patients that I've developed over the years, working with people with these symptoms, and I've learned a lot from my colleagues in GI motility clinic and rheumatology, other specialties, and I've tried to kind of put together some of the more effective principles that can help manage symptoms in these patients. These are not treatment strategies that have been tested or proven in any way in long COVID, but because we really don't have proven treatment strategies for many of the symptoms people have with long COVID, we really end up applying the tools that we've used for very similar, if not the same symptoms in people prior to COVID. So another caveat to this is I don't want people to feel like I've solved the problem here, that we somehow magically manage these symptoms. These are extremely difficult symptoms to improve in a consistent way. In large part, we don't have any proven FDA proven medications for a lot of these symptoms, and often kind of feel like you're flying blind in trying to get the symptoms under control. But here's some basic principles that we try to use. So everyone deserves a medical evaluation for these symptoms. But a major problem with these patients is overdiagnosis and overtreatment, and we really need to be aware of that. Sometimes patients don't really need a huge workup, and they don't necessarily need medical treatment. Sometimes they just need someone to listen to what they're experiencing, maybe tell them that this doesn't sound like a progressive neurologic disorder, and that reassurance actually can go a long way. So education, reassurance is an important component. My personal practice, and I think this is anecdotally proven to be true with many people that I work with, not trying to separate these symptoms into physical or mental health categories, but really working with the patients in a way that they recognize that it really is both. And that, in fact, because we don't know for sure where the specific underlying pathophysiology is, we really need to concurrently target physical symptoms and mental health symptoms and avoid getting in each other's way. So a collaborative approach is probably better. Conservative non-medication approaches are better in general, and we really try to maximize those before resorting to medications. And when we do use medications, really try to avoid polypharmacy by choosing individual medications that might treat more than one symptom area, start out at low doses and titrating slowly. So next slide. Let me go into a little more detail about this. Medical evaluation is not unreasonable for these symptoms, but what we know from research in this area, people who have chronic somatic symptoms, the more symptom areas that you present with concurrently, the less likely it is that you will find a quote unquote organic etiology. And sometimes we have a difficult time knowing when to say stop. People will see a cardiologist 4 times and get the same workup multiple times over and over. So I think we like to have people get screening medical testing, but if that doesn't demonstrate a specific organic etiology and they have this concurrent set of symptoms in these domains, we feel pretty comfortable moving forward with symptomatic management and try to progress from the diagnostic phase to the therapy phase. Also, excessive testing tends to increase the chances of false positive results, which is also a big problem with these patients. That can complicate the diagnosis. It can lead to overtreatment and more confusion for the patients. Next slide. So reassurance. I think for these patients, part of the problem is the lack of understanding about the source of their symptoms. They're working with multiple subspecialists. They tend to get lots of diagnoses, lots of independent syndromic diagnoses. That sort of reinforces that there's something wrong, but nobody can exactly tell them why it is that these symptoms are happening. And that can sometimes lead to thinking like, is this really some underlying progressive neurologic disorder that hasn't been discovered? Do I need to keep looking for more specialists or find that specialist who's going to be able to solve my problem and tell me exactly what I have? And that is not helpful in managing the symptoms for the most part. It's also useful to point out to people that often these symptoms, for the most part, these symptoms don't progress the way a neurodegenerative disorder would. They tend to follow a flare pattern. And in fact, most of the time, the symptoms are going to get better if someone's kind of experiencing a symptom flare, almost regardless of what we do. So there is some reassurance in that. And sometimes people really just need to be heard. They just want somebody to listen to the symptoms and be able to tell them this is not something that we need to do additional testing for. It's something that we see commonly. Need a little bit of reassurance rather than further testing and medical interventions. Next slide. So mention that concurrent therapies targeted at physical and mental health symptoms are probably more effective, I think. Next slide. So we don't really know causation. We know that there's this association between the occurrence of physical and mental health symptoms. And we really can't ignore one side of this equation or the other, or assume necessarily that successful treatment of one side is going to improve all the symptoms on the other side. So a collaborative approach really does make practical sense. Also, there's lots of ways you can think that improvement on one side could improve treatment on the other side. So for example, if we're able to get sleep under control, sometimes exercise is much more accessible to patients. They can be more successful with the conservative strategies that help with physical symptoms. Vice versa, if someone's anxiety about their symptoms kind of makes them feel like they've lost control of their body, if we can find a couple strategies to improve physical symptoms, then people might feel a little bit less anxious about the symptoms that they do experience. We also have to recognize that sometimes the therapies that we're using on the physical side may conflict with therapy on the mental health side. So for example, if we're using medications that really blunt some of the physical symptoms people experience, that could have an impact on desensitization therapy. On the other hand, psychoactive medications often have side effects that are mediated by impacts on the autonomic nervous system that can negatively affect physical symptoms. So we just kind of have to be aware of the treatment strategies being used on either side. Next slide. So exercise has been shown to be helpful for all of these physical domains and for mental health. It's really something that we think of as a core component of the conservative strategy for managing symptoms in these patients. And one of the problems, though, is that the ability to participate in an exercise program is highly variable, from people that are so deactivated that they spend all their time in bed or on the couch and they really can't jump right into an exercise program, all the way to people who are already maybe walking a mile or two a day and are not really particularly deconditioned. So we have to tailor exercise programs to the individual. Next slide. The most commonly used exercise program for postural tachycardia syndrome is called the CHOP-Levine protocol. I put a link to a PDF that explains this in exquisite detail at the top of the page here. This is a good exercise program for people who really have predominant postural symptoms, cardiovascular symptoms like lightheadedness, palpitation, and maybe they still have fatigue, but it's a little bit less prominent component of their symptom presentation. Sometimes if patients have concern about their ability to do exercise, if there's question about their level of conditioning, we'll start by having patients do an exercise treadmill test or a cardiopulmonary exercise test to get some objective evidence for their level of physical conditioning. That's not something we always do, but that can sometimes be helpful. Also, sometimes patients do better starting these therapy programs with physical therapy supervision. They can be taught how to do the exercises appropriately, and someone can help guide them to tailor the level of treatment. The keys to the exercise program are really not to overdo it, to provide some encouragement to progress, but also to provide some breaks so that people don't overdo it, develop fatigue, and drop out of the program. Also, I think it's important to set expectations appropriately. People will not get 100% better because of an exercise program. Typical improvement is more like 20 or 50%. It's worthwhile. People notice the difference, but they can't expect to necessarily get to 100%. So that's important in keeping people engaged in the program. Next slide. Sometimes people don't have physical conditioning at a level that will work for this CHOP-Levine program. It's just too intense for them. And we start with a less intense program that's really designed for chronic fatigue syndrome. This is also a good program for people where the fatigue component or maybe fibromyalgia type muscle and joint pain is a more prominent symptom. So in this particular program, the goal is really to start off with very low intensity activity, trying to keep heart rate at or below 100 beats per minute. People will do better exercising in a seated or recumbent position. And we start off with very low duration, maybe 5 to 10 minutes once or twice a day. If they tolerate that, then we slowly advance to a goal of about 20 to 30 minutes of sustained low intensity activity daily. The ultimate goal then would be to transition from this chronic fatigue program to something more intense like the CHOP-Levine program. Some people actually like to add gentle stretching to this. That's maybe more helpful for people who have fibromyalgia component. Some people also like to incorporate breathing exercises or meditation relaxation strategies to this exercise program, so the total duration is a little bit longer. Some people can't really even tolerate doing the chronic fatigue program. For those people, we really try to focus initially on pacing strategies, sort of thinking as pacing as a minimal activity program, getting them to be able to manage their activity level throughout the day, and then try to transition that into the chronic fatigue program, and then ultimately into something more advanced like CHOP-Levine. Next slide. So there are some specific conservative strategies, non-medication strategies for postural intolerance and chronic fatigue syndrome and postural tachycardia syndrome, or POTS. Hydration is often something that's somewhat helpful for people, maybe a 20 to 30% improvement. Typically, 64 ounces per day of fluid is recommended, in addition to increased salt, which is needed to hold on to the fluid and increase hydration. Salt recommendation is about 5 to 10 extra grams of salt a day, which translates to about 2 to 4 teaspoons of table salt. That's a lot of table salt. You don't want people taking that all at once. It'll give you a horribly upset stomach. It needs to be kind of distributed throughout the day to be absorbed effectively. Some people will find compression garments helpful. Part of the mechanism of POTS is pooling of blood in the lower extremities on standing and decreased cardiac return. So we try to overcome that by applying some squeeze to the legs and pelvis. This can be helpful, but these garments have to be very tight, and they're a bit uncomfortable and hard to get on and off. So they're not something that people wear around the house. And they also have to go above the waist. So that can sometimes be a problem for people with digestive symptoms. Often these patients have symptoms that are sensitive to environmental temperature, particularly hot environments. And over the last couple summers, we've been experimenting with having people wear cooling vests to try to help with body temperature regulation, and that seems to be helpful for some patients. Next slide. There's really no FDA-approved medical therapy for POTS, but there are some things that have been observed to be helpful. One of the goals of medications really is to improve symptoms and not necessarily just vital signs. So symptoms are subjective. They can really be hard to assess. People with POTS often experience both postural and non-postural symptoms. So their symptoms aren't entirely about blood pressure and may not all respond to blood pressure medications. And even when we kind of normalize blood pressure and heart rate measurements when we take them, that's not always associated with improved quality of life. So I think the focus here when we're using medications really has to be on improvement in physical symptoms, and even more so noticeable improvement in people's ability to do physical activities, participate in activities outside the home and work environment. Next slide. So this is kind of a table of the general strategies for POTS. We use volume expansion with fludrocortisone. That's a mineralocorticoid. It can be helpful for some people. Have to be a little bit careful because it can result in hypertension and low potassium levels. Beta blockers, particularly non-selective, centrally acting beta blockers like propranolol, can be helpful. Have to be careful that they can have an impact on mood. Sometimes they can worsen fatigue, low blood pressure, bradycardia. In principle, it can worsen asthma. Ivabradine is a medication that's primarily used for heart failure. It slows heart rate down very selectively through a different mechanism than beta blockade. It doesn't reduce contractility, so it doesn't lower blood pressure. So it actually is a pretty nice mechanism for somebody with POTS. It can cause some headaches and visual disturbances. We also use side effects of a medication that we've used for years for myasthenia gravis, this pyridostigmine. This medication is known to increase autonomic signaling, both on the sympathetic and to a greater extent on the parasympathetic side. So by enhancing autonomic signaling, it provides some blood pressure support, reduces pooling in the legs, but it also increases the braking power of parasympathetic signaling on the heart rate to slow standing heart rate down, increases digestive motility, can increase tear and saliva production, and that can help with dry eyes and dry mouth. Midodrine and droxidopa are both medications that directly cause vasoconstriction. They're more powerful. They can be useful at lower doses, but we have to be careful not to cause hypertension, particularly supine. Sometimes people really have symptoms that almost entirely look like hyperadrenergic symptoms, and they will develop postural hypertension. And in that case, we might use a sympatholytic like clonidine. And in rare circumstances where medications and conservative strategies don't work, many people actually respond quite well to IV crystalloid, normal saline infusions. This is somewhat controversial, but in my experience, it is very consistently effective a strategy for managing symptoms. Even though it's effective, the duration of the effect is fairly short, a couple days, and we really don't want people to use this as a chronic treatment strategy. It's more of a rescue technique. Next slide. Let me really quickly touch on some therapies for chronic fatigue syndrome. There really isn't any specific medical therapy. We try to provide supportive therapies. We try to look for comorbid symptom areas that we do have some tools that we can manage. So screening for sleep disorders, mood disorder, headaches, trying to get headaches under better control, pain management if it's present. Improvement in those areas can lead to secondary improvement in fatigue, and that seems to be more successful than trying to treat fatigue directly. Cardiovascular conditioning seems like it can help. Sometimes it's difficult to get people to participate consistently. Relaxation training, biofeedback, CBT, or other strategies that can be helpful. Next slide. Again, there's really no proven medical therapy specifically for fatigue. There may be a role for stimulants. That's something that we don't use as a first-line treatment. Modafinil is sometimes used, but it's probably better for sleepiness than for fatigue. Low-dose tricyclic antidepressants at night have some anecdotal evidence for being helpful. If there's pain, like fibromyalgia type pain, duloxetine, pregabalin, or milnacipran could be a medication option. And if single drug therapies are ineffective, sometimes a combination of medication like fludrocortisone for postural symptom support plus an SSRI or SNRI may be useful. Next slide.
And John, can I mention, so we have about 4 minutes left, and there's a question that popped up that's something we've talked about a lot that might relate to this slide. Pointing out, so there's this post-exertional malaise phenomena that causes a lot of distress and can be, made worse by exercise. And I know you talked about some of the pacing components, but not in this language. Would you be able to comment on how that plays into how you present exercise and talk about it?
Yeah, so a common finding, actually kind of a defining or characteristic feature of fatigue is that people have a sense of a limited amount of energy to spend in the day. And there's sort of this threshold beyond which symptoms will really take off. And it's not just fatigue. There seems to be, at least subjectively, cognitive symptom worsening. We also see that blood pressure tends to go up, heart rate goes up, people have greater postural symptoms, their digestive symptoms get worse, they have greater pain, they tend to have more frequent headaches, and sleep is more disrupted. So it's something that seems to affect a lot of these different symptom categories. And recovery can take a day or longer. So the challenge is to try to get some of the benefits of exercise without pushing people to the point of surpassing this energy threshold and driving symptoms up. And in particular, you want to avoid getting into a situation where people overdo it and then have 1 or more days of recovery. And that's part of the rationale for this lower duration, lower intensity exercise program. Anecdotally, keeping heart rate at or below 100 tends to have a lesser impact on fatigue than an exercise program like the CHOP-Levine program, where target heart rate's more like 120 to 130, and that tends to drive fatigue up much more quickly.
Joe, do you want to pick one question?
Yeah, thank you. Okay, this is the end. This is the last slide. Okay, thank you, Dr. Oakley, Dr. Hendrickson, and yes, recruitment is ongoing. So there was a question about a potential participant as well. Yeah, thank you for going through this. This is interesting. Symptomatic conditions, clearly a large part of clinical practice, and identifying ways to move forward clinically and not feel stuck and try to help individuals. Yeah, a question, you addressed one of the questions as well. One came up related to stress in general. If you categorize that or measure it more as acute stress, chronic stress, if it's more of a daily hassle versus more of a substantial life event, and if you measure CRP along with that and some of the in-person evaluations. Comment on the stress.
Yeah, so I think that's a really good question. And one of the reasons in our future directions, the sort of what type of stress over what time period, I think is really critical. What we've looked at so far is what's most familiar to me, which is traumatic stress of the type that would probably meet criterion A for PTSD. So it's something that you expect to have a really significant impact on your overall physiologic state for a period of time, right? And how does that relate to chronic stress? There are lots of theories, as there have been for a very long time, and very little sort of unification to understand it, but it's a really important question. And we will get labs, including general inflammatory labs for the folks who come in person. I'll also throw in, we would love to increase the age limit. And if you send me an email, we've been talking about doing that, and I can send you an email if we implement that, but we can't yet.
I think another comment on the impact of stress is something that is commonly observed. We've got this concept of stress as maybe an initiator of a state, something that may or may not be reach the level of PTSD. But another way you could think about stress, most of these patients will describe a pattern of symptoms over time that sort of follows a flare pattern where the symptoms tend to worsen rapidly and then slowly improve over a longer period of time. And not always, but often there are physical or mental stressors that seem to act as triggers for these symptom flares. When the flares happen, symptoms in all these different areas tend to get worse in parallel. So there seems to be a role for stressors, maybe in the initiation of the state, but also as these kind of ongoing provokers of symptom worsening.
Perpetuating the symptoms, really, yeah, or the symptom flares. Clearly that raises questions about stress reduction, or what the stressors are, and if that's an area of intervention. We are over, maybe a brief response on that. Yeah.
Yeah, so I think that the separation of what kinds of types of stressors might cause an initial change in your nervous system that could increase susceptibility to future events, separating that out from the types of stress that might then be able to precipitate or perpetuate flares is really important. So it may well be that you need something pretty significant to cause the initial increase in susceptibility that actually causes a persistent change, but that persistent change may not be obvious until there's another stressor overlaid on top of it. So it could be, and I think about this with PTSD a lot, right, that we can do a lot with our psychotherapies to reduce, intrusive symptoms and sort of the immediate core PTSD symptoms. And people can do a whole lot better. I love our therapies. And sometimes, 3 years later, a totally different type of life stressor will come up, unrelated to the initial trauma, but some of those same physical and cognitive symptoms will reemerge. And that may be a hint that there's something that's sort of sticky about how somebody's nervous system has learned from their prior experiences that can react to even lower grade stressors in different ways in the future. And we don't have any clear understanding yet of what we can do that does or does not unwind those initial types of changes.
Interesting. Well, an area that certainly clinicians can relate to here and understand the importance of this, and really thought-provoking about what's coming next. Even these final comments about strategies to even consider reducing risk of symptom recurrence, a complete, an area also with additional studies and of great interest. So I realize we're a couple minutes over here. I want to thank both of you for working together to do a joint presentation and finding a time that's feasible and practicing it clearly and covering topics in a very informative way. So thanks to both of you, and we'll end it there.
Thanks so much.
Yeah. Okay, take care.